and hospital length of stay. Particularly in our ageing population, so patients aged over 65 that had a fall from less than 1 metre, and some people call it silver trauma, others call it older person trauma, and those groups are at particular risk of developing the secondary complications of multiple painful rib fractures. So why is it that rib fractures are so bad? Well, essentially it's because, to begin with, you develop very severe pain. And that pain prevents you from taking big, deep breaths and coughing. It can be associated with multiple other underlying lung and thoracic injuries. All of these things kind of build up to cause impaired ventilation. As a result of that, you get secondary atelectasis. And as a result of that, you can get a secondary pneumonia or ARDS or respiratory failure. And death is usually as a result of that. And we know in patients aged over 65 who have multiple rib fractures, they're 3 times more likely to develop pneumonia than any of the other age groups. So anything we can do to intervene at a pain level as early as is possible is going to have a positive outcome for our patients with regards to morbidity and mortality. For the most part, patients who have moderate to severe pain were traditionally managed with opiate analgesia. But as we all know, and I'm not going to labour this point, opiate analgesia causes delirium, it causes a reduced cough, decreased diaphragm output, reduced secretions. As a result of that, you get a higher risk of delirium and respiratory failure. So where possible, we want to avoid opiates. Which brings me on to our ultrasound-guided fascial block planes. They're simple, they're safe, they're effective, and one of the best things about them is that they're opioid-sparing, which means that we can reduce that significant morbidity and mortality, particularly in our older patients with rib fractures. So how do they work? Well, fascial plane blocks are a bit different than other regional anaesthesia techniques, in that they involve injection of a large volume of local anaesthetic into a fascial plane. And what you're doing there is targeting nerves that lie within that fascial plane, but also the surrounding muscles and tissues that you can reach with the block as well. So when you inject that large volume, you're looking for a spread or hydrodissection along the fascial plane, and that allows distribution of that local anaesthetic along multiple levels, causing really good regional anaesthesia, particularly good for rib fractures. Now, systemic absorption, as you can see over at the side of the screen, is in a small strip here. That's because systemic absorption isn't really responsible for the analgesic effect of these blocks. But it is an important consideration nonetheless when you're doing any regional anaesthetic technique, that you consider the potential for local anaesthetic systemic toxicity as a result of a large bolus injection of local anaesthetic. So who should we be doing these blocks on? Well, the battle score, most recently validated as the STUMBL score, but containing the same kind of categories, is a clinical predictive scoring system for ranking the probability of complications associated with rib fractures. Some people find it useful. We haven't instituted it in our department yet, but I can see why it would be beneficial. Essentially, what you do is you calculate the patient's likelihood of developing complications, which will help guide their requirement for which level of care that they need, but also their analgesic regime. So if you have your age, say for example you're 50, you get 1 point for every 10 years after 10, so you get 4 for being 50. At number of rib fractures, you get 3 after every extra rib fracture. Chronic lung disease gives you 5 points, so you can see if you've got a 50-year-old patient with COPD, you're automatically on a score of 9. If you've got pre-injury anticoagulant use, you get 4 points. And your oxygen saturations, you get 2 points for every 5% decrease in oxygen saturation, starting at 94%. And really what this does is it brings you out with an overall score. So the battle score was initially kind of brought in but not validated, and more recently the team in Edinburgh have looked at that with the STUMBL score, which is the study of management of blunt chest wall trauma in the ED. And what they found was that a score over 11 signified or correlated with patients requiring admission to hospital for pain management of their multiple rib fractures. They didn't find it was particularly superior to clinical decision making, so I don't know how useful this tool is, but certainly if you're looking for solid ground on why to refer your patient, you might consider using this score. What they did find with Battle's score was that if you get a score over 26, you need to refer for critical care intervention, meaning that the patient will go to either a high dependency unit or an intensive care unit for further management. This score has been reported to have a sensitivity of 80%, specificity of 96%, which is pretty good. Positive predictive value is great at 93%. Negative predictive value is not so good at 86%. So it's not widely accepted and in use yet, but it might be a thing to look out for in the future and good for everybody to be aware of. So Williams et al. In the British Journal of Anaesthesia Education in 2020 published this isolated blunt chest trauma tool, which incorporates a rib fracture score, which is the same as your Battle score. So in that they found if the score is 1 to 10, you get conservative management and you go home. If your score is 11 to 30, you need aggressive management and you need to be admitted. If your score is greater than 30, you need emergency management and you probably need critical care. It's interesting that it's only at this point that they consider assessment for regional anaesthesia. And they also note down here anaesthetic SPR, and if delay likely can be assessed on mortar HDU. So I would urge that as emergency physicians, this is something that we do much sooner in the emergency department. We know that the morbidity and mortality rises with ongoing pain in the first 48 hours, but we also know the first 4 to 6 hours of that injury are really crucial for the patient having enough analgesia on board to take deep breaths and cough and try and prevent that secondary atelectasis and secondary pneumonia. The Plymouth team published this in the same paper, and this is kind of much more practical approach, I'd say, for managing these patients. So they've instituted this locally, and we do something similar in our department. So regional anaesthesia decision tool in rib fractures. So if you've got anterolateral fractures and you're unable to sit, roll, you've got spinal fractures, you've got a collar on or morbid obesity, you get a Serratus Anterior Plane block. If you've got posterolateral fractures that are unilateral and you're able to sit or roll to the side, you can have an Erector Spinae block or Serratus Anterior or paravertebral or epidural block if per effect from Erector Spinae or Serratus Anterior. And I'm going to talk about this just in a slide or two, but it is important to mention that the epidural and thoracic epidural in particular is still the most superior form of analgesia and is superior in all of the clinical evidence base in terms of its pain profile and its improvement in pain scores and reduction in morbidity and mortality. But the issue is the feasibility of delivering that block in a busy emergency department. There are multiple cardiovascular and neurogenic potential kind of complications. So it's a high risk thing. It does require expertise, and it's not something that we're doing in RED currently or that I can envisage that we would do moving forward. So if you've got bilateral fractures as per this decision tool and you're able to sit or roll to the side, you get offered a thoracic epidural by our regional anaesthetic colleagues, bilateral paravertebral block or bilateral Erector Spinae block or bilateral Serratus Anterior Plane block. So just to highlight here that this is one of the beauties of these fascial plane blocks is that you can do them bilaterally, and we'll talk about that a bit further on. So which block for which patient? Well, as I just said, the thoracic epidural anaesthesia is the most superior and should be offered in patients who have severe pain scores, but again, it needs to be performed by a regional specialist, I would say. Do you agree, Orla? Yeah. And it's not suitable for delivery in the emergency department. I'm putting on this very busy, crazy slide, not because I want you to read it, but just so that I want you to be aware that there are other fascial plane blocks in the anterolateral chest. We today are going to cover Serratus Anterior, superficial and deep approaches, but there are multiple others. And similarly, for posterior chest wall blocks, there are multiple other blocks that you can do, but we're only going to cover the Erector Spinae Plane block. So now we're getting a bit further on to the nitty-gritty of how do we actually go about doing the block, the fun part. And we're going to go back to the basics very briefly, because I'm not sure what the crowd is in terms of level of experience and background. So for any regional anaesthesia technique, the real basic stuff is that you're able to identify the sonoanatomy, that you're able to optimize the image, and that you're able to guide the needle. So those are the three things: identify the sonoanatomy, know the normal anatomy, optimize the image, and guide the needle. So in terms of getting the appropriate image, the first step is to choose the correct transducer. So this is a linear transducer, so named because of the shape of the footprint. So it's a high frequency probe, and it's good for imaging superficial structures. In the ED and ICU and colleagues from medicine and respiratory medicine in particular, we're very used to using this probe for vascular access, both peripheral and central, but also for our lung imaging. So the first step is to make sure that you've got your linear probe and that you know what sonoanatomy you're looking for. So on the right of the screen here, we have an image, a static image of what you're looking for with your serratus anterior nerve block scanning. So this hyperechoic shadow with a black shadow behind it is a rib. This bright white hyperechoic line is pleura. The muscle belly here is serratus anterior. Above it, latissimus dorsi, and then this is skin and subcutaneous tissue. So hopefully you'll be able to see that on our live models later on as well. Now, SORA is a fantastic reference point. If none of you are aware of it or not using it, it's really super, and a real wealth of information is available online and through FOAMed for regional anaesthetic techniques. So NISORA recommends that you optimize the image using the mnemonic part. So they seem to be quite into mnemonics. I'll talk about another one in a minute or two. But the P stands for pressure, which basically means that you're applying enough pressure on your probe that you're bringing your target into close proximity, or as close proximity as possible. Your alignment, obviously you need to be over the structure of interest, and similarly you need to have your echogenic needle in an in-plane technique in alignment with your ultrasound beam. Rotation then is about moving the probe around and tilting, same thing, to try and bring the needle, echogenic needle, into clearer vision so that you can track it all of the way through the tissue as you advance. In terms of the technique that we're going to use for our nerve block, it's an in-plane technique, and what I mean by that is, if we have a look at the infographic over here with our ultrasound probe and the beam, and this is our target, say vessel, but similarly, could be anything. This is our echogenic needle here. So you can see the beam is quite broad and wide, and we get all of the tip of the needle. We can visualize it from the tip all the way through to the hilt here. So as much of that needle that is in the contact with the beam with the ultrasound, you'll get an image of on your screen. So that means that you can follow your needle under direct vision and image it in its entirety as you move through the structures. So this is a Blue Phantom task trainer. It's actually a vascular access task trainer, but this afternoon we have some regional anaesthesia Blue Phantom task trainers that we're going to show you. And what you can do is practice your in-plane technique. So making sure that you are following the trajectory of the needle in its entirety. And if you lose sight of the needle, this is where the part comes in. So pressure, alignment, rotation, and tilting. And again, that's something that we think we might be able to demonstrate a bit better on the Blue Vascular Task Trainer. So all our regional techniques are in plane. Better to practice on a task trainer first as well, rather than a real patient. So if that isn't something that you're used to doing, please practice on a task trainer first. This is opposed to the out-of-plane technique, which you can see you've got your probe in a transverse orientation, so you're getting a cross-section, and I hope you can understand and appreciate that the beam is much thinner in distribution, and you may, at any one stage, only get a cross-section representation of that needle, but you don't know where the needle tip is. Now, as you get more skilled and experienced, you can learn to needle track the tip of the needle in an out-of-plane technique or in a short axis, but it is something that requires a bit more skill. So for our regional anaesthesia techniques, we're going to use an in-plane technique always. This is a video that I'm just going to show you very briefly of hydrodissection. And basically what it's going to do is this person is injecting 3 mils of fluid, and as they inject, they're advancing the needle. So I hope everybody can see at home that there's anechoic black fluid being injected here. So this is called hydrodissection. And this is a nerve here, very hyperechoic, honeycombed in shape. And this is a traditional nerve block. The blocks that we're going to do are fascial plane blocks. So we're injecting that same black strip of fluid and looking for it unzipping, which is really what you want to see in your fascial plane block. So the Serratus Anterior Plane block, the thing that we're all here to talk about. And why is it good? Well, it's really, really good because it's simple, it's easy, it's effective, and we can all do it. So why should we do it? Well, it's very good for anterolateral rib fractures, as I've already mentioned, but it's also really good analgesic for patients who need chest drain insertion. And so I think in the future, this will become a mainstay of analgesic for putting in a chest drain to begin with, to be honest. Because chest drains, particularly open drains in trauma, are extremely painful and uncomfortable. And if we can provide good regional anaesthesia, we might be able to minimise the amount of sedation that we need to give those patients and secondary complications from that. So those are the indications for the ED, and in terms of rib fractures. There is other scope for Serratus Anterior Plane blocks in terms of breast surgery and thoracostomies and all of this stuff. But today we're focusing specifically on pain relief for rib fractures. In terms of contraindications, they're pretty much the same as contraindications for other regional anaesthetic techniques. That's local anaesthetic allergy if the patient refuses. Surgical emphysema, a lot of air within subcutaneous tissue, can make it very difficult to image the Serratus anterior. It's not a complete contraindication. You can still have a look to see whether or not you think you're going to be able to deliver that block. It's going to be more difficult. So I'd certainly have a look at the anatomy first. It's not a total contraindication. And probably the most important thing to say is that anticoagulant use does not contraindicate use of a Serratus anterior plane block. And that's really important because in our patients aged over 65 with multiple rib fractures who are at high likelihood of developing secondary pneumonia and potentially having a negative outcome, including death as a result of that, a lot of them are on novel anticoagulant therapy, and those are the population where they're at very high risk of developing delirium already. So we really want to avoid opiates in that group. So it's great news that this plane block avoids opiates, but also it can be delivered to patients who are on anticoagulants. In terms of complications, it's really very minimal: bleeding, infection, failure, essentially, and beyond that, the only thing specific to Serratus anterior is that you can maybe have a transient winged scapula because of the local anaesthetic distribution around the long thoracic nerve. So in terms of anatomy then, this is our Serratus anterior muscle here with all these finger-like projections, and this is the big, thick latissimus dorsi, thicker in some of us than others, I might add. And where we want to put the block is in the fascial plane between these two muscle bellies, so where are the arrows going here. And what we're going to get then as a result of that is paresthesia in T2 to T9 dermatomes. So we're blocking the lateral cutaneous branches of T2 to T9 intercostal nerves, but also the long thoracic and thoracodorsal nerves. So this is a mixed sensory and motor block. Nysora, again, if I go back to them for a minute, they have recommended this particular mnemonic for getting ready for your regional anaesthetic procedure, so they called it scanning. I don't know whether you find it useful or not. I've modified it a little bit, so when you go to the Nysora website, it's not the Nysora preparation checklist. It's just a slightly modified one by me. So S stands for sterile supplies, C for choosing a comfortable position. A, I've changed to mean making sure you've got your assistant ready, and that you've got an anaesthetic toxicity plan. We've got someone who wrote the national guideline on local anaesthetic systemic toxicity in our audience today, so that's exciting. N is for notes. The other N is for needle, transducer and preset selection. I for IV access and monitors for your patient. N for noting the probe marker orientation before you begin. And G for gain and depth adjustment in your pre-block scan. So for those of you who don't have a regional anaesthetic or nerve block trolley in your department, this is a photo of a nerve block trolley that's actually not our nerve block trolley, because ours is right here at the moment. But this is a nerve block trolley that was brought in one of the other departments in Dublin by an excellent trainee called Aoife Fox. The reason I'm showing you this is because it's just to demonstrate that different departments have different trolleys, but it's a very, very useful piece of equipment to have everything stored in one place, and also from an ergonomic perspective of having everything easy to access and doing things as quickly and as efficiently as possible for our patients. So you can see that there's a QR code here as well that you can scan for the contents. I believe that brings you to the Connolly Hospital website. Ours doesn't have a QR code on it yet, but we're in the process of doing that as well. And you can see all of the equipment that you'll need is labelled here. So essentially sterile supplies, block needles, your ultrasound probes and covers, and then a mini pour for your patient at the end as well. In terms of comfortable positioning for serratus anterior, you can do it either in a supine position with the arm abducted, which is excellent because a lot of our trauma patients are going to be kept in spinal precautions and kept supine. So it's super that we can do that. We can also do it in a lateral position. Now, the lateral position is easier for performing a block from an operator perspective, purely because of ergonomics, I think. So if I had a choice between positioning, I would choose to perform the block in a lateral position for that reason. But it's great that we can do it in a supine position too. Whichever position you're doing it in, you do need to be aware of ergonomics. So that's both your position in terms of how are you standing and situated in relation to the patient. Where is your ultrasound? So it should be kind of directly opposite you, within reach. Where is all of your equipment? Should be very close to hand, roughly on your left or your right side equipment and assistant, both sides. And I'll show you the setup that I would use for doing a right-sided serratus anterior block now shortly. In terms of dose of local anaesthetic, we're going to use 0.3 to 0.4 mils per kilo of 0.25% levobupivacaine. And we choose levobupivacaine because of its longer duration of action. So it has an onset of action in about 15 minutes, which is great, really, isn't it? Imagine you could have your patient with their multiple traumatic rib fractures sitting out, chest drain in, and comfortable in 15 minutes, taking big deep breaths. Imagine that fit to sit in 15 minutes. So 15 minutes for onset of action, and duration of action is 12 to 15 hours. That's for a single shot block in ED, and that's what we're doing in our department, is single shot blocks, but then following up with pain team referrals for the patients so that they could subsequently have a catheter inserted by a regional anaesthetist, and the block topped up and repeated over the next hours and days. For the most part, like I said, these are volume blocks. So for serratus anterior, you're going to use between 30 and 40 mils. And remember, I talked about local anaesthetic systemic toxicity. Because it's a volume block, you do need to consider that before you go any further. So the max dose of levobupivacaine, 0.25%, is 2 to 3 milligrams per kilo. And you shouldn't exceed more than 150 milligrams in one single dose. So we take a deep breath. and work out the maths of that. 0.25% solution is 2.5 milligrams per mil of concentration, or 25 milligrams in 10 mils. Everyone got that? Yes. So if you have a 70 kilo patient and you want to give them 0.4 mils per kilo, that is 28 mils. So 70 times 0.4 is 28. I used a calculator for this, by the way, so I most certainly would not be doing this in my head. And the reason I'm saying this is because I feel like we should be doing this more regularly, calculating max doses and documenting them, including calculating the intralipid doses before we begin our blocks, because we all know when we've got fear on board and stress, we can't do mental arithmetic, and we certainly can't work out IT solutions. So we can't do mental arithmetic, so you should be documenting this stuff before you're in an emergency situation, is my point. So back to our 70 kilo guy, 0.4 mils per kilo is 28 mils, which is 70 milligrams. So you can see the max dose for him, 2 to 3 milligrams per kilo, is 140 to 210 milligrams. So you can see with 70 milligrams, we're miles away from the max dose. And the other beautiful thing about this is it means that we can do bilateral blocks. So if we wanted to, we could give 2 serratus anterior blocks, one left and one right, and we would just be at the upper dose of what's the maximum. In terms of techniques to avoid local anaesthetic systemic toxicity and improve the efficacy of your block and drug delivery, you know this. There's a couple of things that you need to do with regard to your injection practice. So you should inject small aliquots between 3 to 5 mils and slowly, so about 30 to 45 seconds between your injections. And then you need to seek feedback, and that's both the haptic feedback from your assistant. So what does it feel like as the fluid's going in? Is there a lot of resistance? If there is, you're very unlikely to be in the correct fascial plane, because it should unzip and be beautifully easy to inject your large volume of fluid. So if your assistant is getting a lot of resistance, you need to know about that. You also need to be looking at the screen for feedback in terms of, are you seeing the black anechoic stripe hydrodissection unzipping in that fascial plane? You should aspirate between injections to make sure that you're not in a vessel, of course, and it goes without saying, try to avoid the muscle. If you do develop features of local anaesthetic systemic toxicity or LAST, and you get hypotension or an arrhythmia, like I talked about earlier, you should be prepared to deliver 20% lipid emulsion or intralipid. So the bolus dose is 1.5 mils per kilo over 1 minute. So for our 70 kilo patient, that's 105 mils. So I think we should be calculating that in advance as a good practice and documenting it, that we've calculated the dose of intralipid in advance of giving a fascial plane block. The infusion then is 0.25 mils per kilo per minute, which is 17.5 mils per minute. And if we have that all written down in advance of the emergency, it means if it did come to it and we wanted to do it, it would be much less panicked and flustering. Further things that you need to document in the notes that I think we do badly, I know I certainly do, so I need to improve on that, is informed consent, the patient's weight, and most importantly, the time that you delivered that block, because you want to know how long before you're going to repeat it. You know, has it worked? Is it efficacious? Onset, like I said, is after 15 minutes and anywhere between 15 and 30 minutes. If you've no pain relief after 30 minutes, it's unlikely that that block has worked. And then, of course, the College of Anaesthetists initiative, stop before you block, which is basically a bit like the surgical timeout thing, where you take a moment to check that you've got the correct site, the correct side, the correct patient, the correct procedure, and that everybody knows what they're going to do and what their role is in the procedure that you're about to do. In terms of equipment, then you need to have echogenic needles. So I'm going to talk you through a couple of those when we have a look at our nerve block trolley. But here in Tallaght, we have a couple of types of needles. We have the Plexifix Braun needles that have a nerve stimulator associated with them that they use in theatre a lot, and our regional team use a lot. And then we have plain needles that don't have any nerve stimulator associated with it. So you don't need a nerve stimulator for this. You can use a plain needle that just has a connection port for your syringe to inject local anaesthetic, and there's no nerve stimulation required. You do need to use an echogenic needle so that you can follow the tip all the way up the hilt, like I showed you in our in-plane technique video. You need to have the appropriate transducer, and then you need to pick the correct preset on your ultrasound machine. And the reason that you need to pick the right preset is because it'll auto-adjust the depth and the gain depending on which preset you pick. And I might show you that again in our live scanning session in a minute or two. Your patient then, you need to have IV access and monitors. They need continuous ECG, blood pressure and oxygen saturation recording. And that's really, for the most part, for monitoring for local anaesthetic systemic toxicity. The next thing to do then is to perform a pre-block scan. So basically that's like your recce scan where you're having a look at the anatomy. So remember our 3 steps: identify the underlying sonoanatomy, optimize the image, and then guide the needle, okay? So identify the anatomy first, so do a pre-block scan. Your landmarks are you want to be in the 5th intercostal space in the mid-axillary line, and that's in the supine position and the left lateral position. So essentially the same landmark pretty much as a chest straight. It's an in-plane technique. So what you're going to look for then, and the anatomy is going to look a bit like this. So you're going to have latissimus dorsi with subcutaneous tissue sitting just above it. Then your serratus anterior muscle, hyperechoic rib with rib shadow, intercostal muscles here, and the bright white hyperechoic pleura. So for serratus anterior, there's actually 2 approaches that we can use. The superficial approach, which is injecting local anaesthetic between latissimus dorsi and serratus anterior. So you inject into the fascial plane between those 2 muscle bellies and look for your hydrodissection, and you're unzipping along that fascial plane with the volume block. The one thing to avoid there is the thoracodorsal artery. So you should put your colour Doppler on so you can identify the thoracodorsal artery before you do your plain block injection, just to make sure that you avoid puncturing that. That's it in terms of the superficial approach. The deep approach then is going underneath the serratus anterior muscle belly. The reason I think that people prefer the superficial approach, because there's no evidence for one being superior to the other. People seem to prefer the superficial approach because it's further away from the pleura and they feel like they're less likely to puncture or damage the pleura with the superficial approach. But actually in practice, both are very easy and straightforward, and you're far enough away from the pleura that pleural puncture is very unlikely if you have an appropriate in-plane technique. And so the first step in practicing this is to practice your in-plane technique. So in a lateral position, our probe will be placed on the chest wall here in the 5th intercostal space, mid-axillary line, probe marker towards the nipple. And this is just a schema showing where the serratus anterior muscle is on a person, with pec muscle bordering it anteriorly and latissimus dorsi muscle bordering posteriorly. So the latissimus dorsi gets bigger as you move further back or further posteriorly. So if you've got too much of latissimus dorsi in your view, you know that you're not anterior enough. Similarly, you can decide on which approach you're going to use, and this is just another schema showing the serratus anterior muscle, your rib with rib shadow. This is latissimus dorsi coming in here, subcutaneous tissue here, and the deep approach is underneath the serratus anterior, above the external intercostal muscles, or the superficial, which is between your serratus anterior and your latissimus dorsi. This is an image showing the thoracodorsal artery on colour Doppler, so that you just know where it is, so that you can make sure that you stay away from it and that you don't puncture it during your nerve block. Important to aspirate as you infiltrate for that reason. And this is just another schema showing the superficial approach and the hydrodissection along the plane that you're looking for when you're doing your superficial serratus anterior. Now we're going to look at a very quick video of the deep approach. So you can see our echogenic needles coming in here, and this is the anechoic black stripe that we get as the local is infiltrated. So if we have a look now at that one more time, so this is our anechoic local anaesthetic here, This is our hyperechoic rib with rib shadow beneath it. This is the bright white hyperechoic pleura, and this is our local anaesthetic infiltration, and that's the posterior or deep approach. This is the superficial approach. So for this one, you can see that we're going to inject the local anaesthetic in between serratus anterior here and latissimus dorsi over here. So you can see the needle here advancing, trying to get into that fascial plane. We're going to see some hydrodissection, so anechoic black fluid, 3 to 5 mils, then stop, 30 to 45 second pause, and you can see it's unzipping there along that fascial plane as the block is delivered. So that is our serratus anterior nerve blocks. There's some excellent training video resources available. This is a particularly good one, the GE Venue serratus anterior nerve block, but we're going to skip that for now and just go on to our Erector Spinae Plane block. Talk very briefly before we get into our practice, which is the mainstay. So Erector Spinae Plane block, also super easy, simple, safe, effective, and really fantastic block. A brilliant skill to have to look after patients with posterior rib fractures. Contraindications, same as the Erector Spinae, there are very few. Local anaesthetic allergy, patient refusal, and that's pretty much it. In terms of complications, there's sometimes a concern here as well that it could cause a pneumothorax, but that's pretty much it then. Bleeding, inflection, failure, same thing as before. In terms of preparation, we need to go through exactly the same approach as we did before. So I'm trying to teach you sort of consistency in the approach to preparation. You should prepare as much as you possibly can, mentally rehearse the procedure before you do it as well, and to improve your performance. So in terms of sterile supplies, we're going to set up with our same regional anaesthesia nerve block trolley with sterile gloves, sterile ultrasound gel, sterile probe covers, our cleaning equipment, our appropriately sized nerve block needle, and of course our 0.25% levobupivacaine. In terms of choosing comfortable positioning for this block, the Erector Spinae, it can be performed either sitting or pronated, or you can do it in a lateral position. Now again, I think it comes down for the most part to user familiarity and what you're most comfortable with. I prefer doing it in a sitting position, but I think it's really just to do with the fact that I've done more in a seated position. So if your patient is in spinal percussions, this is not the block to choose. But if the patient has posterior rib fractures in particular, this is a really fantastic skill to have to help the pain relief. So make sure you've got an assistant, you've got your local anaesthetic toxicity plan, you've made the appropriate notes of the patient's informed consent, their weight, time, and you stop before you block. Pick your appropriate needle transducer preset, make sure your patient's set up with IV access monitors, and note the probe marker orientation, gain, and depth in your pre-block scan. This is the basic anatomy, and if we have a look at this here, it represents the spinous processes, and as we move laterally away from the spinous processes on the chest wall, we're going to move out towards the ribs. Okay, so for this block, we're going to start at the level of T5, the thoracic 5 vertebra, and we want to start about 3 centimeters from the midline. That's what this means. So there's a lot going on here, but I'm just going to explain it to you in a really simple way. So identify the midline where your transverse process is about the level of T5, start 3 centimeters from it, and then you're going to scan medially. And as you do that, you're going to be moving from ribs towards the transverse process and the spinous process, okay? And as you do that, you're going to see your circular, semicircular rib shape flatten out as the transverse process comes into view. And with that, you're going to see a third muscle belly come into view as well. So traditionally, you would see your trapezius, your rhomboid, and then as you move more medially, you're going to see the Erector Spinae muscle. When you inject your large volume fascial block here, you're going to get extensive hemitruncal block because you're blocking both the dorsal and ventral rami. So you can see it's really, really fantastic in terms of the amount of anaesthetic effect that you can achieve with this block. So this is another schema to try and help everybody at home understand the anatomy. We're going to do the live anatomy scan now in a second, but centrally thoracic spine. You want to be about level of T5. You start about 3 centimetres away from your transverse process over the rib, and you scan medially until you see the rib semicircular in shape change to transverse process more square in shape. And with that, you can see the 3 muscle bellies come in. So you've got trapezius, rhomboid, and erector spinae. And that's the view that you want for delivering this fascial plane block, where you're going to inject your local anaesthetic underneath your erector spinae muscle and look for unzipping and hydrodissection and spread along that fascial plane. This is another schema with a representation of what your probe position is going to be like. So this is Keflad Kodad positioning. Here is your echogenic needle, and you can, interestingly, perform this block either from above or below. So it really does come down to what you find more comfortable and better for your ergonomics, I would say. I find it easier to do it from above like this, but I don't know, do you do below? Yeah, so we've got a regional anaesthetic specialist in the room with us today, and she does below. So we'll show you both and see whichever you prefer. And then, like I said to you, these are the 3 muscle bellies that you're looking for: trapezius, rhomboid, and erector spinae, sitting in front of your hyperechoic, squared off transverse process. And you're going to inject the local anaesthetic volume block in here and watch for that hydrodissection along the fascial plane. So this is a very brief video, but we might skip that in the nature of time and get on to our live practical scanning session. So for the erector spinae block, you're going to use about 20 to 30 mils, so it's slightly less volume of 0.25% levobupivacaine. And you can expect with that you're going to get sensory distribution and blockade 4 levels above and below where you've infiltrated that block. So remember, you're aiming for around T5, and it's going to go 4 up and 4 down. In terms of erector spinae versus serratus anterior, which is better, the battle of the blocks. The bottom line in terms of the evidence base, but also in terms of my preference, is both or either. I think they're both fantastic. I think it's great that you can do both blocks, both sides, so you can deliver bilateral serratus anterior, bilateral erector spinae blocks if need be. I think the serratus anterior lends itself obviously to trauma patients who are immobilised in spinal precautions, but for distribution of block, the erector spinae is really fantastic and is emerging as one of the front runners in terms of blocks delivered in emergency departments, certainly for early analgesic effect to prevent high dependency unit care and secondary morbidity and mortality from rib fractures. The other fantastic thing about both of these blocks is they're not contraindicated on patients on anticoagulants in the way that the thoracic epidural actually is. So it means that we can deliver them early and we can get that good early pain relief on board to try and prevent morbidity and mortality in our patients. So thank you very much for listening to that very long lecture. And now we're going to move on to do some practical scanning. So this is Niamh. I would like to highlight to anybody watching that Niamh was the winner of the Sono Games, which was an ultrasound competition for medical students. So she did a fantastic job. And so she's our little ultrasound enthusiast here in the department. So it's going to get you to roll on to your left side. So what I'm going to do to begin with is I am going to select my linear transducer. So left lateral position, arm is abducted. So you can see why this is easier for you and for me to do. Now we have a bed that goes up and down. So from an ergonomics perspective, I want her down a little bit. She was a bit high there. So we want to go 5th intercostal space, mid axillary line, okay? So it's gonna look something like this. Okay, so now if we switch over to our ultrasound view, I hope you guys can appreciate that in the mid axillary line, in the 5th intercostal space, we have a rib and we have our bright white pleural line. So you can see at the top of the screen there, we have a rib with a rib shadow, a second rib with another rib shadow. In between, we have the bright white hyperechoic pleural line. Can everybody appreciate that? Yep. And then above that rib, we have what looks like serratus anterior. When we move more posteriorly, we can see the muscle belly of latissimus dorsi coming into the center of the screen, okay? So we want to be in the 5th intercostal space in the mid-axillary line. And when we put our probe on there, we want to look out for the thoracodorsal artery. So I'm just going to put my colour Doppler on for a second and see, can I identify the thoracodorsal artery anywhere in the plane between latissimus dorsi and our serratus anterior. And you can see actually on Neve, I can't quite see it anywhere here, so I'm probably not quite at the level of her thing. I'm just going to move your bra a tiny bit there. Okay, so when we know that we have latissimus dorsi, okay, and this is a hyperechoic rib with a rib shadow. This is the bright white pleura, hyperechoic pleura. So you want to avoid the pleura, obviously. The danger of the superficial approach is the thoracodorsal artery, and the deep approach is, of course, that you puncture this pleura. But you can see you're actually really quite far away from it. So latissimus dorsi here, subcutaneous tissue here, very little of it in our slim friend Neve. And here is the serratus anterior muscle belly, rib, pleura in between. So for our superficial approach, we're going to inject fluid in between the latissimus dorsi here and our serratus anterior here. Volume block, 0.3 to 0.4 mils per kilo, but generally 30 to 40 mils at 0.25% levobupivacaine, avoiding the thoracodorsal artery. If we're going to go deep, we're going to go basically just underneath the serratus anterior over here. So essentially what they recommend is that you just go slightly in front of the rib here and inject your 30 to 40 mils there and look for fascial plane spread. So remembering you're quite far away from the pleura, and if you stay away from that pleura the whole time, then you've no risk of causing a pneumothorax. And even if you did, you could look for it on your ultrasound afterwards. So I think pneumothorax lung scanning might be for another day. But superficial in here, above the serratus anterior, deep approach down here beneath the serratus anterior muscle. And in terms of using our model to demonstrate the anatomy in a supine position, we're going to switch to us to video. Okay. And I'm just going to show you what the anatomy looks like in a supine position. So our model is now lying supine, as you can see, and she's very, very thin. So there's the rib is where my arrow is right now. So I'm in the mid-axillary line and the 5th intercostal space as we speak. If we move forward, we're moving into pec major. And if we move back, we're getting a big, thick latissimus dorsi come into view. So as I do that, you can see, I might just demonstrate with the ultrasound again. As we move back, we get a big, thick latissimus dorsi come into view. And as we move forward, we move into pec major, and also around about here, you're starting to get into breast tissue as well. So you want to be in the mid-axillary line around here, with latissimus dorsi just coming into view at the top of the screen there. And our serratus anterior muscle sitting just in front of our ribs. So we can reduce the depth there. Okay, and then what we're going to do is we're either going to inject in here, just in there, the arrow, yeah, in there for our superficial approach, 30 to 40 mils, 0.25% levobupivacaine, or in there for our deep approach, which is 30 to 40 mils of levobupivacaine again. So the superficial approach, the concern is, or the risk is that you could hit the thoracodorsal artery, and then the deep approach, then the concern is that you could hit the pleura. But if we look at that, we're actually miles away from the pleura. You're really far away. So if you're able to guide your needle safely, then there's very minimal risk associated with this. So the serratus anterior block, it's really easy, firstly, and secondly, it's really beneficial. So we're going to move on now to do our erector spinae. So if you sit up for me, Neve, and can I have the video on me, please? Okay, so for our erector spinae, again, we're going to use our linear transducer. We're going to adjust the ergonomics so that our bed height is appropriate. Our patient in this instance is sitting, but you could be pronated or in the left lateral position as well if you wanted. So we are going to start about the level of T5 and about 3 centimetres from the midline and put our probe on. And as you can see here in lovely Neve's beautiful, beautiful anatomy of Erector Spinae at the back, here we have 2 ribs on the screen. So we have 2 ribs here. Can you appreciate that those ribs are really quite semicircular in shape? So just outline those with the arrow there, semicircular in shape. And then between them, you can see as well the bright white hyperechoic pleura with slide along that pleural line. So here you can see that we've got some muscle bellies on show as well. So trapezius at the top, rhomboid in the middle. And then whenever we move more medially, I want you to look for those semicircular ribs squaring off to become a transverse process. And then our erector spinae muscle coming into view. So can everybody appreciate that that's a much more square looking image than we had to begin with of our rib? So we know that we're in the right place because we're at the level of the transverse process. Then we're going to enter the skin, if you show with the arrow the direction, enter the skin until we come down onto the tip of that transverse process, and then we're going to inject our 20 to 30 mils of 0.25% levobupivacaine, avoiding the pleura beneath and watching for that fascial spread or hydrodissection along the plane. Again, you can enter the skin from above or below if you have a look at my probe positioning now, and I'm just going to show you again. So can you see it on the screen okay? You can scan up all of these ribs and down all of those ribs. So you have 2 ribs on the screen, starting at a level of about T5, and you're going to scan medially, watching those semicircular ribs square off until you've got what looks like a transverse process with your 3 muscle bellies above it, erector spinae, trapezius, rhomboid, erector spinae, in that order. And inject your fascial plane block there. So you can do that either seated, or you can do it prone, or you can do it in a lateral position as well. So thank you so much. Now, the other thing that we have today available for everybody for use is our regional anaesthesia task trainers, which we literally just got the other day. So if I take off the arrow for a second. Okay, so what we want to do then is we want to use our in-plane technique to manipulate the echogenic needle on the screen so that we see the entire length of our needle the whole time. Now, can you see that I've lost the tip of that there? Okay, so the first thing to do, and this is what I wanted to demonstrate briefly with the task trainer, was that you need to be able to optimize your image. So for me, part of the problem here is ergonomics, right? The bed is too low. So I need the bed up is the first thing. Just shows you, you never do things well whenever you're uncomfortable, do you? The second thing that you can do is alignment. So have I got my needle in alignment with my probe? Then do you remember they said pressure, didn't they? And tilt. So what can you do in terms of pressure and tilt? So align your probe, advance your needle, and then you're going straight into your target. Okay. Now, this is pressure to show me my echogenic needle. This is rotation, yes, of the probe. And this is tilt, where I'm pressing more towards that needle with the kind of front of my probe than the back of it. And those are the recommended tips for optimizing your needle trajectory. Okay.
Vicky, can you demonstrate that again with the camera behind you?
Yeah,
cheers.
Sure.
The different movements that you're doing. Yeah, thanks.
So can you put it on me? Is it on me?
It's on you, yeah.
Okay. So this is the echogenic needle, okay, but the Nysora tips for optimizing your image. Obviously, you need to be able to adjust your depth and your gain in the near and the far field. If you don't have enough gain, and that is a big mistake in novices, is they don't increase the gain enough in the near and the far field. So here is my echogenic needle, okay. So to optimize my image, if I don't put enough pressure on, this is what the image looks like. Do you see how much sharper and improved that is with pressure? So pressure is the first thing. Alignment is the next thing. So this is out of alignment, this is in alignment. Out of alignment, in alignment. And you see it's a very small movement. Rotation is the same thing, rotating in order to get your alignment essentially of your ultrasound needle and the probe in the one direction. Part of it is because the ergonomics have improved, are improved. The bed's at an appropriate height for me, so I'm comfortable. I'm not stressed out about doing this, able to manipulate my probe and ultrasound beam to make sure I've got a view of that entire needle the entire time that I'm manipulating it, okay? So pressure, alignment, rotation, and then tilt, okay? So tilt is when you put more pressure toward one end of the probe rather than the other. So you want to be able to put enough pressure on that you can see so I'm going to go through this vessel just for the purposes of this, just so that you can see the entire trajectory of that whole needle. Does everybody appreciate that? Now, if I tilt the other way, that's what I get. So if I tilt away from that needle, that's what I get. Tilt towards, and I get this. Tilt away, and I get that. Yeah? Does everybody want to have a go? Yeah? Okay, there's one over there as well, MMA, if you want to have a go with an echogenic needle over there. Okay, so what we're going to do now is we're going to start our practice. The other thing I forgot to point out on our video, can you tell me, can you see it? But this is our new regional anaesthesia trolley, okay? So here it is. It's fancy pants because it's got a rotating ergonomic iPad for optimal positioning. I've set out the equipment that we need in advance. So our sterile pack, Chlorhex, our sterile gloves, our ultrasound gel and the probe covers, and then a couple of different needles. So these are the Fascial needles that we have from Braun. So we do use ones that have a nerve stimulator, but it is much cheaper to purchase the plain Fascial needles that don't have a nerve stimulator. It's just because of the hospital kind of policy here that we use the ones that have a nerve stimulator, but it's not necessary. So do see, can you invest in needles that are much cheaper? This is our nerve block trolley. I can't see if I can see.
You can see. You can see.
We can see you. And Vicky, why do you have an iPad? What's the iPad for?
So this is for our handheld ultrasound that we use for our nerve blocks.
Yeah.
So we've got a handheld ultrasound that goes here. This is our iPad for the scanning, and we can position that in any way that's appropriate for our patient or for us to maximize the ergonomics. The top of the trolley is for our sterile equipment. We place our handheld ultrasound probe back in the ultrasound box, and then we have sterile supplies, needles, drugs, and documentation. And we also include in that where to access the intralipid within our department. So this is our new nerve block trolley that we're very excited about. It's not actually been introduced onto the floor yet, but maybe after today. We still need to get the QR code organised so that we can order everything in a one-shot sort of approach. But the nerve block trolley is really a fundamental for doing emergency department nerve blocks. It just improves everything in terms of ergonomics, delivery, safety, speed. So if you haven't got a block trolley, I'd actually recommend that that's the very first step. And ask, are there any questions about that? And thank you very much to everybody who's joined in and listened. I hope you find some of it beneficial.
Yeah, thank you very much, Vicky. Well done. That was a big challenge. So I think you and your team did really well. So thank you very much.
Thanks. I don't know how useful that was. I don't know if everybody could.
Lots of nods in the room here.
Okay. Well,
so well done. Yeah. And there's a bit in the chat that people saying thank you. So well done.
Okay, well, if you have any questions, please don't hesitate to contact me. Serratus Anterior and Erector Spinae are really fantastic, and we're using them all the time in our department, and certainly we think it'll become a mainstay of treatment everywhere. Are you using them a lot, Chris?
So we do it sporadically, but not frequently enough. So we're trying to develop a chest pain pathway and deciding either ESP or serratus anterior or both. So that's a bit controversial at the moment. So watch this space for us.
What about the Plymouth approach? Their chest drain tool, their analgesic tool?
I don't know about that. So I'm not directly involved in the chest pain pathway. I've got someone here who is, but I'm just trying to organize the ESP side and serratus anterior plane block teaching bit.
Okay, well, there's a couple of really great video resources as well that I was going to talk about, but we were getting kind of pretty close on near time to do a bit of practice.
Well, if you could put the links in the chat, is that okay?
Perfect, I'll do that.
And then I'll try and get the people to practice here this side. We've got a machine and a volunteer, so we'll I think we're going to sign off.
Yes, fantastic. Thanks so much, everybody. Best of luck practicing. Hope you enjoy it. Bye.
Thanks, Vicky. Thanks very much.
Thank you.
Well done. For everybody else, if you've got feedback for how to make this better or any other topics you'd like us to cover, we're going to try and run this every month, once a month, and possibly more if we can get more people on board. So yeah, just give us a feedback. Thanks very much. Okay, see you again soon. Bye.